So welcome everybody. I'm delighted that there's so many people here today. And this is the Health Equity Network. This is the webinar for June, and the subject is place-based working. And we have two great speakers today. First of all, in a moment after the introduction, we'll go to Kathryn Cross, who's the Service Development Lead at the Integrated Wellbeing Network at the Nora and Bevan University Health Board in Gwent. And Kathryn will be talking about her work in that area. And then after that, we'll have Jessica Allen, who's the Deputy Director at the Institute of Health Equity, who will be giving us a perspective from the Institute, but also across several areas where we have been working with different boards and organisations around place-based working. I'll also just introduce myself and Alison. My name is Alan Higgins. I'm the Health Equity Network Lead working at the Institute of Health Equity. And it's particularly relevant for this webinar that I also mentioned that for 2 days a week, I work in Cheshire, Mersey as part of the Public Health Collaborative, where I'm the strategic lead for implementation of the Marmot programme. So I'll be contributing something about the place-based working in that area as well. And Alison, do you want to introduce yourself?
Yes, sure. Hi, everyone. My name's Alison. You probably get emails from me quite a lot. I manage the day-to-day function of the Health Equity Network with Alan, and I work at IHE in a number of kind of administrative capacities, but it's great to have you all here today, and thanks so much for taking your lunch hour with us.
So, thanks, Alison. Most of the usual rules of webinars works here in that if you're not speaking, if you can stay on mute, and you can submit questions through the chat or comments through the chat, and you can raise your hand if you want to make a point when we get to questions and discussion after the two speakers. We do, like I say, encourage people to stay on screen, and if there's an opportunity, I will come to people to invite you to make a comment or to make a question on screen as well. So, introduction, I'm going to quote from a What Works Scotland report from a couple of years ago about place-based working. And it mentions, it says, place is a physical setting and social context, rich in meaning, although what a place means and to whom is highly contested and frequently challenged. It offers a holistic, whole-place approach, crosses policy sectors and silos. It sounds tangible, immediate, and local. It's something an individual can identify with, a place to live, a place of work, and a place to care about and protect. However, at the same time, place can easily become a catch-all for a range of potentially inconsistent policy agendas. There's a risk that it becomes weakly specified, poorly evidenced, and a receptacle for odds and ends. But place-based approaches have great potential to support community-led initiatives, particularly if they're linked to wider investment and poverty reduction strategies. So that's the context for what we're discussing today. Place-based approaches are talked about a lot. They're also difficult to fit into practice, but we do have some great examples of how they can actually work. So with that as the introduction, I will hand over to Kathryn Cross, Service Development Lead, Integrated Wellbeing Network, and our own Bevan University Hospital Board. Kathryn.
Thank you very much, Alan, and thank you everyone for giving up your time to be here today. I am just going to try and share my screen, and hopefully the tech will be kind. Yes, I think it is going to be kind.
Looking good.
Brilliant. If I can just share my slideshow. Excellent. So thank you, everyone. My name is Kathryn Cross, and I lead the Integrated Wellbeing Network programme for a place in an Nora and Bevan Health Board called Blaenau Gwent. It's South Wales, and there is one of me in each of the 5 boroughs that make up the footprint of a Nora and Bevan University Health Board. Some of my colleagues are on the call or are on the webinar at the moment, so hopefully if I get stuck on any of the questions that you may have, they'll jump in and support with the answers. So we've been in post since 2019, and obviously our work was disrupted by the COVID pandemic, as everybody's was. But that did also gave us some opportunities to accelerate some of the elements of our programme in the communities. So we work on the basis that we've got lots of assets in our communities, and it's about harnessing the potential of our communities to increase well-being in the populations that we live. So we don't work across the whole of our patches, our whole of our boroughs. We have specific towns that have been identified for us to work in, with a population normally up to around 10,000. And we work specifically in those towns to increase well-being through the integrated wellbeing network. It's not about doing more, as I've said, it's about harnessing the potential and the services and the support and the people and the hearts of those people that live in those areas. It's about getting people to help themselves. How can people help themselves in the area that they live? And this is we call this our plan on the page, which illustrates what we're trying to achieve. We're trying to strengthen the assets that we have that already are there in our communities, harness those relationships and build on them that are already there, and make sure that the place that people live have the provisions that they need to be able to support their well-being and access services when they need them. I'm going to give you a quick overview of the 4 objectives that we are trying to implement in our patches, and then I'm going to give you some examples of how we've gone about doing that. So each of the areas have implemented it differently, depending on what people in the community tell us. So it's not a one-size-fits-all. It is adaptable to what the community tells us, what they need, and where are the gaps in provision and the support that they need. So you can see the 4 main objectives on this screen better than you can on the previous screen, and it is all centred around place, people and provision. So objective 1 is about coordination and developing the wellbeing resource and coordinate it in the areas that we work. And I will give you an example of how we are tending to do that in our areas. The second is to identify ways that hubs can be centres for wellbeing resources in the community. Now, as we know, hub is a term that's branded, it's bandied around a lot at the moment. Everything is a hub. If you can stick hub badge on it, it will become a hub. But I'll go into explain and give you some examples of the ways that hubs and the resources that we have in our communities can really harness and support the wellbeing of communities. Objective number 3 is all about the wellbeing workforce and the people that deliver services and support. So when we think of a workforce, typically we may think of people that are employed. But our wellbeing workforce is anybody that lives, works or volunteers in our communities, because we all have a part to play in wellbeing. And I think that traditionally, we all know that child protection is everybody's business. I think the wellbeing is also everybody's business, and everybody can have a part to play in increasing the wellbeing of their communities, whether it be big or small. Some people, everybody has something to lend. And the 4th is about easy access to wellbeing information. So it's lovely to have all that support and all that information and everything going on in the community. But if people don't know about it, it's absolutely pointless and fruitless if they can't get hold of that information that points them in the right direction of services and support. So I'm going to take you through some examples of how we are implementing that in our different areas. And also, Aneurin and Bevan Health Board are now embarking on becoming a Marmot region. So that lends itself really nicely to the work that we undertake, and they complement each other quite nicely. So the first objective, which is about establishing a collaborative, this is an example from Blaenavon. And how it's happened there. So Healthy Blaenavon is a collaborative that has been set up in Blaenavon. And this is community-led collaborative and professionals bringing them together to listen to each other. It's about the partners, the key partners that work in that town. So the police, the GPs, housing, the town council, the third sector, all of those professionals that work in that town. It gives them the opportunity to come together outside their day jobs to share information, to share information about what they are doing in their patch, how they can work together, and give them an opportunity to build those relationships so that we can take forward activity. building relationships is a really important part of our programme, and is basically the basis of everything we do. If we can't build relationships with the professionals and our communities, then we aren't going to achieve what we set out to achieve. So it's really important. And I think one of the examples during the pandemic that helped us was because this collaborative was already set up in Blanavon, it was really easy for GPs and social workers to be able to point people in the direction of support and services that they needed right at that time, because that information had been shared with the collaboratives, so they didn't have to go searching for it. And the branding is also recognised and has been adopted by the community. And because the community now see that they have a role, they have come together to develop and put into place new initiatives such as exercise classes for over 60s, family clubs and cinemas, because they saw that as a gap in their provision in their communities. And we're able to work with the professionals in the collaborative to bring those to fruition in a way that they owned and they knew that would be acceptable to their communities. So those connections are really important in the work that we do. Again, it's asset-based and community-driven, based on what the community is telling us and listening to responding to what matters to them. The second objective is around our community hubs. And this is an example from Blaenau Gwent. So in Blaenau Gwent, we are trying to establish a network of hubs. So it's our community wellbeing network of hubs. We approach different buildings in the community that do lots and lots of really good work, but it's all done in their silos. By bringing them together as a network, they're starting to share information about what they offer, share resources, and share ideas about how they can work together. We've got identifiable branding, so we worked with community members in those towns and they came up with the slogan Blaenau Gwent in this together and agreed the branding that is displayed at the front of each of our community hubs, so people know that when they walk in there they will be able to get advice and support to access services in their communities. The hubs have all also agreed to have a wellbeing notice board or a wellbeing table where they can advertise what's available in their area. And provide support. Many of our hubs have also agreed to have cuppa and company sessions, which has been accelerated because of the cost of living crisis and getting people back into the communities from COVID. And we also hold network meetings. So we bring these hubs together bi-monthly to talk about how they can work together more and what are the gaps. So it's a two-way process. We give them information to give out to people that they see about what's happening, but they also feed back to us about where are the gaps in the community. What is happening, what are people saying are the issues in the community. So it's because they're on the ground every day out there, they see it, they talk to people all the time. So it's definitely a two-way relationship between us as the IWN team, the community and the professionals we link with in the collaboratives. Our third objective is around the wellbeing workforce, and that, as I've already said, wellbeing workforce is anyone that lives, works or volunteers in the community. And how can we harness the ability to get information out to our communities, but also get information in? So there's a number of ways we've approached that. Each of us have our own branding that has been developed in the areas that we work, and you can see some examples there on the screen. We produce newsletters that go out electronically and sometimes hard copies to our communities and our professionals, so they know what's going on. We've produce desk guides for our GPs, so it's a really quick reference guide that they've got on their desk to help them signpost to people to services in the community. We provide training sessions, so for example in Blaenau Gwent, some of our hubs have said that they are really struggling with training such as first aid or food hygiene, we have been able to go back to the collaborative and say this to them and say that it's an ask. And then professionals have come forward and said, well, I'm able to offer that to your hubs free of charge, as long as you can get us the venue to hold that training, which we can because they're already a hub. We also hold briefing sessions, so we can go into team meetings, we can go into sports venues, we can call into community groups and give them briefing sessions just around what is a reliable source of information. We know that community members and some professionals use Google to find information, and sometimes you don't always get the right results. But if they know where to go to find out information, that's a real benefit for the people that they work with, or they don't get disheartened when they don't get the right results when they Google it. So reliable sources of information are really important to share with our wellbeing workforce. And our last objective is around easy access to wellbeing information. So I've already talked a little bit about the newsletters and the hard copies. One of the issues that we do have in the areas that we work is that people are digitally excluded. So we need to make sure that we don't rely on just solely on the internet to get information out there, because wellbeing information is so important. And that's why we use our hubs to get our information out there. We use our wellbeing workforce. They know how to look it up and signpost people. So some of our areas, not all of them, but some of them have developed something that we called an interactive town map. And the one that we see on our screen here is your Newport, your wellbeing. And the interactive town map is a useful source of wellbeing information, and it enables people to peruse the map for their town. So it's a town, it's town developed, so they can either search for things in the search bar, or they can click on the different subcategories we have that will highlight where those activities are happening in their town. Or they can click on a building and they can look at what is happening in that building. If they see that there's a choir in their local community centre and they click on the choir, it will then take them to either the website for that choir, the choir's Facebook page, Dawis, or back to the community hub where they can find out more information about that provision. One of the other things about the map is that we have it in different languages, so people can bring it up in the language that is preferential to them, and they can search for it that way. So we also work with our local radio stations and our local partners, that we put information out through them. We also have something called our Wellbeing Friends, and Wellbeing Friends are members of our community, so they either live or work in our areas, and they sign up to becoming a wellbeing friend for that area. On doing so, we will then send them emails with information about what's happening direct to their inbox. And our ask is, look at the information, and if it's relevant to you, brilliant. If you read something and you think it's relevant to one of your friends or families, please pass it on to them and let them know about it. And that's all we ask them to do. And we get really good feedback from our residents about becoming a wellbeing friend. And we also have Facebook pages for each of our areas specifically, so people can either, it's not reliant on us to post things, we might manage those Facebook pages, but people are able to post their own activities that are happening or any issues they have on our Facebook page, or ask questions about if anybody else knows what is happening in the community. So that is our integrated wellbeing network in a nutshell. Sorry, it was a really, really whirlwind tour, and I'm sure you've got questions. So if there's, oh gosh, and I don't know what I'm doing now, pressing everything I shouldn't. I will end my show and stop sharing. Thank you for listening, and thank you, Alan. I will hand back over to you.
That was wonderful, Kathryn. Thanks so much for that. There have been some questions, and one of your colleagues has responded to some of it, but I will come back to it after we've heard Jessica's presentation as well. Some great slides there too. One brief question from me is just, can you give us some sense of how long it's taken to get to that point from when you started this work?
Yes, well, majority of us came into post in around May 2019. So that's how long we've gone, but obviously we had the pandemic in between. And sometimes it is 2 steps forward and 1 step back when you work with communities and professionals that have different priorities. But I think we are starting to get more momentum now because we are sort of embedded in those communities.
Excellent. Right, we'll pick up that discussion again in 15 minutes or so time. But I'll hand over now to Jessica from Institute of Health Equity.
Yeah, many thanks. I'm Jessica Allen. I'm Deputy Director at the Institute of Health Equity, and I've been there since 2008. I joined for the original Marmot review and stayed put. We've been involved in a lot of work. So today I'm talking about the work that we've been doing across the UK with places, but just to set that in context, and I think it's important, this context, the approach that we've taken really is to push anywhere and everywhere that we can, and we've been working globally. We've done a number of global reviews and regional reviews, the Americas, Middle East and so on. We've worked with a number of countries, so we've done plenty of country reviews, and increasingly, and it's interesting that it's increasing, we've been working with local places in England. At the same time, we work with organisations and sectors, so the UN, WHO, the community voluntary sector, business, public services, local government. And again, I think that's absolutely vital part of what we do, is this kind of organisational and place-based work. So I just wanted to provide a bit of context. We also do a lot of thematic reviews, which come under the social determinants of health. So we've been building this evidence base, really, along with many other people. I shouldn't, there's plenty of organisations doing very similar and important work. It's not just our institute, of course, but we've got a huge evidence base now on a whole range of areas and the importance that they have for health, good examples of what to do about them, how to do it. And just to highlight these recent ones, this one on structural racism is coming out in November, and I think that's going to be an important review, structural racism and health. So these are our Marmot principles based on all the evidence reviews, the key drivers of health. I think they'll probably be familiar to many of you. These are the key social determinants of health, covering the life course, starting very young, running through education, young people, employment, income, and social protection mechanisms, healthy, sustainable places and communities. Thank you, Kathryn, for the previous presentation, information about what's happening in Gwent. Role and impact of ill health prevention, and of course that's the more traditional public health, racism, discrimination, disability, gender, and age, and environmental sustainability. 7 and 8 we've added since the original Marmot review, but really increasingly important, I think, and wider recognition of the importance of both those areas for health and for health equity. So, given all of this, just to reflect on where I think we're at and what we need for action. So the leadership and the system is absolutely critical. And when I talk about the system, it's all those partners that I mentioned at the beginning, and I'll come on a bit to those. And a lot of the work that we do is really trying to get those partnerships well aligned, established. They're difficult, you all know that. They're really difficult, but there's ways of doing it, and there's kind of mechanisms which support those practical tools, levers, accountability, legislation, regulation, or sometimes it just comes down to one individual who's really pushing forward this agenda and is able to take an organisation or a sector with them. But we would like to see it more embedded in the levers and mechanisms. So you need all of this kind of leadership and system, I think, and a lot of what we do in places is really support that leadership and build that system, build those partnerships. Capacity is crucial, of course. Everybody in the workforce needs to know what it is that they can do, how they can contribute. And we usually find when we go into a place that everybody's very willing and keen to make a difference, keen to make an impact. We very rarely get any pushback on, this shouldn't be a priority for the area. We don't agree with the social determinants of health approach. We get a bit of pushback about competing agendas and so on. But people are willing and want to do. The main barrier is what can you do in a place given all the constraints that we know. So we've got an enormous amount of evidence about the issues and the need for action in these areas. We know what to do, so don't let anyone tell you, oh, we've heard this many times actually, particularly from national organisations, national government, oh, we haven't got enough evidence, we don't know what to do. We do. We may not present it in the right way, we may not do the exchange of information, but there is so much activity which is brilliant and making a real impact. It's the scaling up and the knowledge and awareness about that. So I just want everyone to know that there is a very strong evidence base behind the social determinants of health, health equity issues, and increasingly around what's needed for implementation and the kind of interventions which are really effective. Resources, of course, resources, and increasingly, we're hearing about the cuts everywhere is having to make again in the context of it. So we frame that in the way that, these cuts are extremely damaging for health, and actually they're really uncost effective in the long run. They damage people, they damage communities, they damage the economy. Everybody prioritises health. We're actually actively damaging health through some of these cuts, and we make that case very strongly. But of course, there are significant limitations, so we'll try and work around that. And then we make recommendations for action in all these areas. So we make the recommendations in those thematic areas, the Marmot 8, and we also always, when we're in a place, think very hard and work collaboratively with the health equity system, consisting local government, of course, all the different divisions of local government, healthcare, increasingly important. Healthcare has an enormous impact on health through the social determinants of health, as well as through its services, of course. So we focus more on the social, what the healthcare organisations and system can do to improve outcomes in social determinants of health. There's a lot. The voluntary community, faith, social enterprise sector, public services across the board. I've just noted a couple there, but across the board, public services, enormous impact on health. And of course, everything, these different organisations and sectors do tend to be very siloed. But as soon as you make the health equity case, it gives them actually greater clout for what they're trying to achieve. Reducing inequalities in educational attainment reduces inequalities in health. That gives them additional clout to make their case and to invest in that. And business in the private sector, this has been a fairly new piece of work that we've been doing with the private sector. And I think through the pandemic, there was greater awareness from business in the private sector about the extent of health inequalities, what that meant, and increasingly what that means for their own economic position, their recruitment, retention, productivity of their own workforce. National government and organisations, of course, are part of this health equity system, but as you're all no doubt aware, we've had a lack of focus from the national government. And of course, much of what we talk about is actually quite political. These are political decisions, resource investment, where we're talking about structural drivers of health and inequalities. The national government often has other priorities, particularly recently, so we've been trying, but importantly, we know that other places are picking up the mantle and taking action independently of what national government is or isn't doing. So that's really encouraging. And the work that we've done with places has really taken off in the last 4 or 5 years. Before that, we had Coventry, which became a Marmot place in 2013, but all these others have come on since the pandemic. Greater Manchester during the pandemic, and then we've had interest from all these other regions, towns, places, and increasingly we're getting more and more and more interest from places, I haven't listed them all here, who want to do something on health inequalities, despite all the cuts, despite the lack of insistence on it, lack of accountability from national government. There's a real interest in developing places. So that's encouraging. And I think, we can prove using this, thinking about what we can now say to national governments is if you take action locally, this creates momentum. We can show what can be done. It's a really exciting movement, really, that's happening among these local authorities and the integrated care systems and so on. So we go into place. I won't go into the detail of what we do. We analyse what's happening. So this is looking at all the outcomes in those social determinants of health, health inequalities, and importantly, the system and how well that system that needs to be in place, how developed that is, how strong, what are the barriers and the blocks to the action that we want to take. We develop collaboratively recommendations for action, and that's a really important process. And so much of what we do actually is around the kind of convening, accelerating existing work, and just bringing a framework and a structure to what's already happening in places and hoping to push a bit more. So although we have had positive impacts, and lots of, I'll come on briefly to some of those, but mainly it's in this process, it's in the development of a system, it's getting health equity in all areas, all policy, health equity in all policy. And once you start thinking about that, we see changes in how the housing sector is approaching housing issues, how education might be approaching issues for young people and so on. So we've tried to put health equity in the centre. We then report, there's a report and a launch and so on, and a monitoring framework. That's also been really important, partly because it enables us to see what's happening, evaluate what's happening, but also because it brings all those different stakeholders together in the process of prioritising what's important in the development of those indicators, and then agreeing that these are the key areas that they need to focus on. So the monitoring and development of an indicator set has been really important. And then there's the process of implementation. So there's a whole range of things that are happening. Every local area is different. You know, the recommendations we make are different. We have a framework, but all the recommendations are different. The implementation's different. And I can't say that any place has ever taken our work and just gone, yes, we accept all of this, we're going to do it all. Of course not. It's different in every place, but there's been movements and prioritisation of particular issues in different places. We're now working with Leeds in the southwest, and they're prioritising children, young people and housing, children, young people and housing in the southwest, and crucially, a big piece on return on investments, which of course will help us, we hope, make the case around the allocation of resources. Leadership has tended to be with public health. We're getting increasing interest from integrated care boards and some healthcare organisations, but generally public health has led it. Coventry, I mentioned, since 2013, they've got all the partners lined up. They meet regularly, I think monthly, and we don't have any sort of formal relationship in Coventry anymore. It's great. They would do this work without us entirely. They have their own system. It's been really effective, I think. And if you talk to people in Coventry, they'll say that it's this convening power, this advocacy and getting health equity in all policies. They all sit down together and identify issues together. West Midlands Police, for example, you know, meeting with all these other partners, and I think it's become a really important mechanism, having this steering group, this partnership working. Greater Manchester, we reported, as I said, in the pandemic. There was quite a bit about building back fairer and the impacts of the pandemic. And then Manchester City developed their own implementation plan and local response. So in every place that we work, things are happening, and there have been important shifts. As I said, we haven't got a kind of silver bullet that reduces health inequalities overnight. Simply, we'll often ask, what are the one or two things that you would do in a place? It's different in every place. We push on open doors. I won't go into the detail of this, but we recently had a 1 year on event in Cheshire and Merseyside, and Alan's been working there on the implementation, which has been really helpful. So I'll whiz through so that we have time to discuss, but there's lots happening in all the places, and of course lots that isn't happening as well. So let's be realistic, there's lots that isn't happening. And there's lots happening in places which don't come under our kind of Marmot Place group. And we hope that the network that we're all involved in really becomes a forum for discussions, not just about Marmot Places, but about what's happening in all those local places, how to unlock some of those barriers, how to maximise the opportunities that are there, and so on. And in terms of healthcare, just to briefly mention healthcare, we've had lots of interest from healthcare organisations wondering what they can do on the social determinants of health, which is great. We've done various analyses of what can be done, but of course the system changes a lot. But at the moment we're working with ICBs and trusts to really focus on reducing inequalities in health through those partnerships that they have a remit to develop. Through how they spend their money, where they spend their money, accountability on health inequalities, and really strengthening that. And there's 2 or 3 trusts as well who have really been pushing beyond anchor approaches. So the East London Foundation Trust, for example, they have a really strong programme of work linked to all those Marmot 8, and they work with their own workforce. They work with their own clients to support them into good employment, and they work with employers in places to really support good quality work, so kind of advocacy role as well, developing working in schools as well to improve the employment prospects for young people. I mentioned business, that we did a review about what business could do for health equity. Good quality work, absolutely vital, pay, benefits, conditions, as this is their own workforce, but also contractor, the cleaners, the security staff and so on, supporting health through their products, services and investments. We've learned a lot from the climate change movement about the importance of those investments for as a lever for change. You can think about investing in companies and organisations which are taking health and health equity really seriously. And then this influencing role through the partnerships, through advocacy and lobbying, pay tax would be great, and environmental impact. So those 3 areas have been key, and I think that framework's holding up quite well with businesses, and we've seen some positive action. We've got a programme of work now with private sector developers and house builders to look at how they can really make changes in those 3 areas, through housing, development of healthy places, of course, but also their own workforce, construction industry, and into their own investments and their kind of advocacy role. Coventry, they've been pushing businesses to create healthy, inclusive workplaces. There's been a campaign there, and this report was recently published. We were involved in it, looking at big financial organisations in the city, and the role, the health and needs of low-paid workers, contracted workers, who support those organisations, and there's been quite a bit of interest as a result in improving those kind of conditions. So there's a lot happening, but there's also realistically a lot that isn't happening and some significant barriers to change. But given all this activity, I think there's a lot to be encouraged about, and I hope a lot to discuss and unpick, because all of you will have your own experience of trying to implement things in places and doing exactly what I've said is needed, and you will have much more detailed hands-on information about how to do that. Thank you, Kathryn, for the presentation that you gave, which it really did set out in some detail how to do that. So thank you very much.
Thanks, Jessica. That was fantastic. Thanks for covering such a wide range of work in not very much time, but that was really helpful. There's a few people I've teed up to ask questions or make comments from the chat. And some of your colleagues, Kathryn, did respond to the comments, but I think it's worth coming back to some of them. Kieran, could I come to you first of all? You mentioned that you're developing inequalities network in Bath, and you had a question or a comment to make, but would you like to either reiterate the question, but also just tell us a bit about that work in Bath?
Yeah, so just to give a bit of background, so I'm working in health inequalities within primary care. So this is just a new role that started a month ago. So I'm just kind of, finding it out, just sussing. But the main problem that I'm having at the moment really is that we're meeting all these various partners from like local authorities, from third sector, private sectors, like various hospitals. They're all doing great work, but all separately in their own silos. This was obviously like separated by COVID, and especially with the third sector, which continually changes. There's always moving parts. There's always new local initiatives that are going on. It's impossible to get like a full directory of who's doing what in the local area. And I was just wondering how you've kind of amassed the list and continually changed it, because obviously like charities that are going on for a year aren't there next year, and then suddenly you're just focusing all your efforts on a charity that's not there. It's quite it feels a bit like whack-a-mole. So I was just kind of interested in how you've continually updated who's in your network, really.
And our colleagues.
Oh, sorry, just coming off mute. So For us, in relation to, I think, as Em said in the chat, as in relation to statutory partners, they are bought into the integrated wellbeing network. So that's how we get the police, etc., around the table, because they've had sort of the nod to, you will be involved in this and you will change the way you work in. With the third sector, you are right, it's very difficult, and we get asked all the time, can you share your directory? We don't have a directory because you will never keep it up to date. It changes, as you said, all the time. But what we do, we have that network, so people, because we're now well established and we did all that footwork at the beginning, meeting everybody, we link in with our voluntary association. So any groups that they are involved in and know about, they will point in our direction, and they will also let us know when people are no longer operating. And with the ones that pop up that we don't know about on a very local level, because we are known in the communities, other members of the community will say, you need to be a part of that collaborative, and we'll point them in our direction. We are also really lucky because not only do we have us as leads in the areas, we also have our community, we have like a community worker on the ground in those small place spaces, so they are the eyes and ears on the ground to what is popping up and what is disappearing on that very small geographical area.
Thanks, Kathryn.
Yeah, that sounds really helpful.
I'll bring in Victoria for a comment.
Hi, yes, I'm CAT's equivalent in Newport, and I was just going to add, I think because we are place-based and there's very much a focus on place and smaller areas, we also have collaboratives that work in that place space, and they're multi-agency networks, everything from the police to third sector to community groups to housing associations. So I think it makes it a little bit easier that you get that up-to-date information, because people are coming regularly to meetings and working with each other, and you're working with the community groups and the community hubs. And like Kath said, then we've got a community involvement officer that is constantly sort of assessing what's available, and we're helping to promote that. I think the fact that it is on a smaller scale helps in terms of that update. But it's like, but then when we do work across the city, in my case, a bit higher, more strategically, it is very, very difficult. And I think we've just had recent conversations. It's full-time jobs to sort of keep those kind of social media, directories, interactive maps. It's a very, very hard job to keep up to date. But I think every organisation, even the voluntary organisations in with us, have got their own directories. But I know they face a similar situation. I don't think we know what the answers are, really, do we?
Thanks, Victoria. We'll bring in Adam from Greater Manchester on similar subject. Go ahead, Adam.
I'm not quite sure what you want me to specifically share, but I can say briefly about what we do locally. Would that be useful?
Yeah.
So Manchester divided itself into 12 neighbourhoods. This was part of the devolution that happened of Greater Manchester and integration of health and social care. That 12 is now turning into 13, but each neighbourhood has a leadership team which brings together different people from different bits of the NHS and social care, and includes my role, which is a health development coordinator role, and we're community development experts in for each neighbourhood. So it's different in different neighbourhoods since the pandemic hit, but in the neighbourhood that I cover, we have an almost monthly neighbourhood health partnership meeting, which has a mailing list of about 400 different people across a huge range of statutory and health partners, as well as voluntary, community and faith and social enterprise sectors. And so not all of those obviously can make a monthly meeting, but they all get the notes and the presentations from the small group discussions. And we get about 25 to 45 people, I'd say, attending the meetings. And they're all tackling health inequalities. They're themed on different topics, which are social determinants. So for example, next week we're trying to set it up for the year ahead and planning priorities, but we've got one on one discussion on life expectancy, so things like diabetes, hypertension, bowel cancer screening, housing, child health, poverty and environment, air pollution, active travel type things, and our mailing list to address the question. The mailing list, we just have to update it as and when it's best possible. We haven't tried, and nor will I try and create asset mapping or share a directory for the reasons people said. There are interesting places in the country where that's started. The startup work for that is done by a local authority, and then they have a system which has a sunset clause, so that if groups don't update it, they just disappear off that. But that doesn't happen in Manchester, so we just do our best as we can, and we cover a population of, it's a patient register of about 60,000, but it's probably kind of near upward a couple of tens of thousands more than that in a very ethnically diverse and socioeconomically diverse area.
Thanks very much, Adam. I'll just bring in Emma for a question about managing resources, and then we'll change tack slightly. Emma.
Hiya, thank you. Yeah, my question relates to other people's thoughts. We led a Thriving Communities Partnership project at a neighbourhood level a couple of years ago. In a community that had a lot of challenges, particularly low income and long-term health conditions. And one of the things we tested was ReferNet, which was a kind of wiki where different groups and organisations could upload their own information, keep it up to date themselves. And the learning from that for us was that the information communication function for any of this type of work is really important and is a professional job that needs doing well. And we weren't able to come out of that pilot with the resource to do it. So I've been trying to talk to our integrated care system about whether they could look at hosting such a thing. I think local authorities were just mentioned there, but for that to work well, it's going to take time to build. It's going to take sort of buy-in across the different sectors and sort of empowering micro groups to take part and make their sort of activities available. And I just think it's a sort of I mean, Kathryn said how important that objective is, easy access to information, and I totally agree. We're struggling to find a solution to it locally, and somebody with the appropriate resources needs to host such a thing and resource it to make it really work, and we all need to be able to participate. I don't know if anybody had any advice.
Thanks for putting that out there. We'll see if people come back to us on that, Emma. I'm going to slightly change tack now because Peter made a comment in the chat which I found intriguing. So Peter Lacey, would you like to come on and give us that build in it?
Thanks. Very quick background. I've spent the last 10 or 15 years working in strategic consultancy in health and care, very much focused on place population health needs and seeing places, both workforce resources and community resources, etc. Spent the last 4 or 5 years, including COVID, in my place, building up community resilience and doing a lot of the things that we saw in the first presentation down in Gwent. But I also, fool me, I got elected as a councillor in our local authority last year, and my question is about how, when the emphasis that I hear is, local authorities are in the lead and it's public health and it's this and that and the other, how, when a community of 25,000 with good leadership across community and business sector, with really big ambitions, can drag a laggard local authority along to be actually part of it. Now, I'm not saying that local authority doesn't have people who understand the benefits of Marmot thinking, etc., but as an institution and as a culture, it is being a drag on what is happening in a local community. And I can see the benefit of big wins, Manchester, Coventry, etc., but actually that they will have weaknesses in terms of what their reach is down into the local. Some of that has been demonstrated in the questions, but how can this movement help a market town of 25,000 who have a leadership structure in place but a laggard local authority to get on? And is it a big hammer to the local authority, or is it just complementing the working at that large scale with working at the, I suppose, the meso scale, or at least the scale that people recognise as their place? So that's my challenge.
Brilliant. That's a brilliant challenge, Peter. I'm going to, Jessica, I'm going to invite you to give a perspective on that.
Yeah, it's a really good question. Hi there. Really good question, and an important one, because we tend, as you've already identified, we tend to work with places that approach us who have a willingness to do this. I guess my advice would be to make the case to the local authority and start anyway. You don't actually have to have the local authority engaged from the very start if they're really a drag on it. If you can't convince them, just do what you can, push on those open doors that you've mentioned already and see where it takes you. Work with the local business community who may be further ahead in their thinking around health equity even. And then I expect other sectors, including the local authority, will follow and express an interest. And you may find a surprising route in to the local authority through the whatever they call their business economic partnership, rather than through their public health, which is the usual route, but not the only route by all means. But other people on the call may have experience of doing exactly what you've asked.
What I've suggested on the network in the past is that there may be other places of similar scale who are struggling with a local authority from whom we can learn and we can share. So I think it's just a question out there to say there may be lots of people. I can see Pam's got a hand up.
Yeah, if you wouldn't mind, I wouldn't mind saying something. I mean, we're sort of gently dragging Devon County Council into the 20th century, I think, in a lot of ways. But we've taken, we're tiny. Where I am is 4,000, and we're working with a cluster of towns that are 4,000 that add up to about 40,000. Because in a lot of times, a lot of places, these organisational capacity is missing. So the community ideas, community passion, infrastructure direction is all there. But they're particularly in the deprived communities that we're working with, they're lacking in the social capacity to actually manage the delivery or funding of everything. So we've literally been doing it like a show and tell. We're very lucky at the moment to have some core funding, but we've been building the people's priorities and then gently that relationship building, bringing the public sector into our realm. And what we found is within the sector itself, there's a huge passion for what we're doing. So at middle to lower middle senior management, the department heads are all, oh my goodness, this could be an absolute saver, because what we're doing is reaching everyone they can't reach. It's doing it incredibly cheaply, incredibly well. But the problem is their focus is on those big high level drivers and their funding issue. And actually it's their senior leadership capacity to really make a radical change. And what we're encouraging them to do is, rather than find a local authority wide solution, is to start some pilots that grow rather than go all in. So, you can keep your aeroplane flying into the cliff, but we all know that shortly it is. But in the meantime, let's build some safety nets in place, which are actually more effective. Now, I think even if there were millions more pumped into the public sector locally, I still don't think they would ever have that answer to working with communities unless they embed community working in. They're going to constantly miss out on those more marginalized communities and the communities that need that help the most. It's relatively easy to reach the most vocally urban centric places. Relatively, it's much harder to reach the needs of deprived people who've been left behind for generations. So yeah, we're doing a show and tell at the moment.
Thanks very much, Pam, and it's great to have us reminded of the work that needs to happen outside the urban centres as well. So I think probably the last comment, I'll hand over to Kathryn, who's going to tell us about successful work in co-production in Blackpool. Yeah, there, Kathryn.
Sorry. Hello. Yeah, sorry, Alan, you dropped out then.
Oh, apologies. I'm Kathryn Neary is what I meant.
Oh, not me, right?
I know you're not working in Blackpool. Kathryn Neary, apologies. Are you there to tell us about Blackpool work? Oh, Kathryn's just said she can't seem to get the microphone to work, in which case we might well be ending on that point. Apologies, Kathryn, and apologies for people who did have some difficulty hearing me during the webinar. That has been really interesting. And perhaps, Kathryn, if you want to send on some information, we'll send that around after the webinar about the work in Blackpool. That's been brilliant. Thank you so much, everyone, for contributing. And of course, you can keep this conversation going through the Health Equity Network, through the various forums, and we will continue with the monthly webinar. And thank you also for Rebecca Lyons, who posted information about work, particularly focusing on, I think, elderly population. And there's other people who have put notes up there as well and links. And Kathy Neary's just put up